Welcome back to the Sports Medicine Project. I'm your host, Blake, with my co-host, Kelly. And today we're talking about how to diagnose one of the most common things that I see. We're talking about metatarsal stress fractures, stress reaction, whichever you want to call them, all-encompassing bone stress injuries. But before we get to that, it is good to be back. Kelly, it's great to have you back.
It's been a while. I don't think I've spoken into this microphone in a good few months. It's been busy lately.
Yeah.
Just had a lot going on.
I think the last episode we dropped was with Greg. I think that was 3.5, 4 weeks ago. And we've got plenty in the bank. We still have been recording. I recorded one about a week and a half ago, but we wanted to have a diagnostics dilemma case study, specific topic to speak about, then have a lovely, intelligent guest come on. But between that, we just got flat out between research, between courses, between work. We've had a bunch of weddings and parties and everything, and we just haven't been able to get away on the weekend.
And then the weekends that we have been free, we've been recovering, because that is important too.
Yeah, that is important. That's important.
We're going to talk about that even in today's podcast.
Yeah.
The importance of recovery.
The inadequate recovery of metatarsals. But what sparked this conversation is I posted a reel on Instagram a while ago, and about a week and a half ago, and if you want to see it, just jump on my Instagram, Blake..SportsPodiatrist. But I just ran through it about a minute's worth of content of how I would go to a really brief diagnosis of a metatarsal stress fracture, because I see them quite a lot. And in that particular week, I'd seen a couple that had been misdiagnosed as something, it's a metatarsal and something plantar. So I did a brief riddle on that, and I thought, why not just expand it in a podcast, because it's pretty easy to diagnose. I say easy in the sense of you can really find the bone quite easy, but we're going to talk about how we go through those clinical tests, what it involves, what imaging is involved, how do we rule in versus rule out, how much certainty do we need to be able to get that in, and what symptoms are we looking for, because it is a really important differential to get right in the forefoot.
Yeah, I think it's good to talk to you about it too, because sometimes I even question when people have a sore forefoot, I wonder how much sensitivity there might just be even over the top of the bone or the metatarsal shaft as well, from some other things that could happen, because there's more sensitivity, say, within the joint space, but then they are still tender to palpate along the metatarsal shaft, because it is so superficial. It's not a super comfortable place to be palpating. So then I'm like, oh, is this a tenderness because that area is sore, or is that just tender because that whole forefoot's tender and that's not a super comfortable place to be palpating? Yeah, keen to talk to you about that.
Yeah, and some of the people just their extensor tendons run over the bone, and if you ever do see and diagnose a stress fracture and then you get a subsequent MRI, if you have a look on the MRI, sometimes they are pretty well lit up with edema and swelling, of course, around the fracture site or around the bone stress injury, but in the surrounding interdigital space, you think, how is someone walking around on that? Because it just looks like there's so much going on there. So if you palpate anywhere around the metatarsal in the space or over the metatarsal, it's likely to be sore. But there are some distinct differences that we can do to rule it in.
Yeah, so let's go through a bit of an overview to kick us off if you want to.
Yes, easy one to remember. So depending on the study you read, between 13 to 20% of all running-related injuries fit under the bone stress injury diagnoses, and that can encompass all of them. As an example, base of fifth met ones are 2%, and I think I'm not going to say it now, but one of them's 0.5. Maybe it's patella. It's incredibly insignificant, but metatarsals are really quite common. So they make up 20% of that 20%. So you could almost say, correct me if I'm wrong on my math, it's 5% of then all injuries.
I don't know if it works like that.
But 20% of the 20%, that I can say comfortably. So tibial metatarsals are going to be the most common. Around 75% of BSIs are either going to be tibial or met, and 55% of bone stress injury in female are going to be tibia or met. And we think of them so closely together, because when we think about the unloading, the reloading, the return to running, depending on if it's high or low risk, it's really, really similar.
So 75% of
all BSI in males. And this
is the tibia and the metatarsals.
Yeah, combined together. But this is done in the cross-country collegiate.
And 55%, because more proximal bone stress injuries tend to present in females. That's what that's indicating?
Yeah, I don't have the data on what the split is, but why I've grouped them together is because when we manage them, we think of them, again, if they are low risk, we think of them as so similar, being loaded by the plantar flexors or the return to run stuff or the reloading stuff. They just fit together.
Do you think what do you think the reason is for males having more below knee bone stress injuries? Do you think it is because they're less likely to be dealing with low energy availability and REDs, or do you think there's something like biomechanically that might be indicating they're more likely to appear
Yeah.
below the knee in men?
I really don't have an answer for that. I mean, you can certainly speculate, but I can't think of anything that I've read. Like, talk about the biomechanics. I'm not too sure of any data that's distinctly shown a real statistically significant difference between males and females. Like, as an example, 50 times more likely for a male to have a longer second met. We know that's a risk factor for developing a second metatarsal stress fracture, and maybe that might bump the numbers up, but I'm not aware of any data. And I don't know about that in foot type. Like, naturally, females have a broader forefoot, higher arch, and a narrower rear foot, but I don't think that would be enough to move the needle. And I don't think I can speculate that because there's
Yeah.
no data. What do you think? I guess, like you said,
I
with
think,
low
yeah, I reckon that must be part of the picture. That would make most sense to me.
Yeah, we posted a big infograph, Bo and I, that was a new study that came out last year. That was across 5 seasons, and it was pretty similar, like tibia and met, which makes you think tibia and met were amongst the most common, but why does that bone fail? It always makes you wonder, like someone
In that one spot too.
yeah,
Or like,
someone was in the clinic, and I think you saw one recently as well, like a tibial plateau. And I'm thinking, why is it the plateau? Like, if you've done enough to overstress that bone, why the tibial plateau? Why not your tibia, or why not your femur? You're assuming that the load to the bone is relatively the same. Like, surely there's not something around how they move or what's happening in their life that specifically loads that area. Do you ever think that?
I do think that. And that's where maybe like biomechanics might come into it more so. Like, you always think, if someone's getting more likely to be getting metatarsal stress fractures,
Yeah.
do you think they're more likely to be on their forefoot, running on their forefoot, higher plantar flexor loads, maybe? But
Yeah.
then I don't know if that's, I don't know.
Well, it still comes down to their training load, regardless of, they're a heel or a forefoot striker, because you're assuming if the training load's the same, potentially they have the same ability to adapt. But then no, because the training load's different. I guess it just changes the location. So rather than a heel striker to a forefoot striker, it just moves the load, and it moves the load significantly. I mean, we had Christian Barton on. I think he was saying between rear foot to forefoot, it's like between anywhere from 15 to 30% change in loads from forefoot to rear foot in regards to moving it from one area of the body to the other. It's one of the biggest movers of the needle. But anyway, talking about stress fractures, the analogy, which I think hasn't caught on yet, I haven't seen anyone say it or I haven't seen anyone use it yet, but the easiest way to think of a bone stress injury, which we talk about all the time, but it is important, and I communicate this with all the people that I see, is it in a remodeling to modeling imbalance? You load the bone too much, you overstress it, it isn't able to make up for that load, and then it can fail, and if it fails badly, we can lead to a stress fracture, which the modeling imbalance, it's probably a bit easier for us to understand, but I think for the people in front of us, I use one of two analogies. I use the analogy of digging a hole, where we assume your bodies are always digging a hole. You're going to take some dirt out of the hole, but there's someone on the other side of the hole that's putting some dirt in there, and the hole needs to say a certain depth. If you take too much dirt out compared to what someone can put in, it's going to lead to eventually a bone stress or stress fracture. Or the other analogy is if you go and get in your car, have a full fuel tank, you go for a drive, you can't drive forever. You need to pull over, you need to rest, you need to refuel, you need to let your bones rest. Naturally, some people just have bigger fuel tanks. They can go further before they run out of fuel or before their bones fail. And that's genetics, amongst many of other things and factors that contribute to bone health, and also many factors that can affect what our fuel tank is. So if you have REDs, we're assuming your fuel tank is very little. If you did gymnastics and you did multi-directional sports, sport and you eat a lot and you train in the gym, we're going to assume your field team's probably a little bit bigger, but that's probably another layer to it. But that's all you need to think of for
I
that.
was just thinking you could add an extra layer to the hole digging one,
Yeah.
where someone's digging the hole, but the person that is refilling the hole has to get their refill from a little bit further away. So there's a bit of a delay for them to come back and refill the hole
That's not
compared to the person digging it out,
Yeah,
because that's what happens with the blast in the class, you know?
Yeah, that's it. There is that.
There's a
that
lag
behind there. Yeah, that's a good one. Maybe you could say.
And so they're just going to keep digging the hole. And if we don't wait for the blast to come in and fill the hole, it's going to take a bit longer.
Yeah, that's a good one.
Or it's more
Say they've got
likely
a little
to.
pile a couple of meters away. So that means you can dig the hole deeper while that guy's going to get that, or girl, while that guy or girl is going to get the rest of the material to fill the hole in, but you can't do it forever. You can't do it too quickly.
You got to stop and have a little water break, a little snack break
I like
while the blasts come in and get to fill in the hole, and then they go again.
Yeah, I like that. If they're if they're medical, and it's always great working if a patient is medical because they get that on a basic level, and you can kind of add that next layer of the person digging the hole, they can dig it really, really quickly. Whereas the person filling the hole, they're really slow. And that's why we just have to go slow with these injuries, because the breakdown of bone can happen very, very quickly, days, weeks, whereas the remodeling and that bone becoming strong again takes a long time. And unfortunately, there's nothing we can do about that. That's just how it is with bones.
I like the hole digging analogy better than the car one.
Yeah.
What are some other things that we need to know about bone stress injuries in the metatarsals?
Yeah, so we're going to talk about, both of us, the subjective questioning, because you can get a lot of what you need purely from that. And then we'll talk about weight bearing and non-weight bearing. But whenever someone has a suspected of a bone stress injury, and I mean, you could certainly make a good faith argument that you would do this with anyone with musculoskeletal pain that's been going on for a while, but we do need to be screening for these systemic factors that we know can have a pretty big influence over bone. I brought up RES before, relative energy deficiency in sport. We should be screening for broader systemic things around the history, the genetics. Do they have anything rheumatological, connective tissue disorders? And there are some really good screening tools out there. But the big one is REDS, and the big one is their history of the process, family history.
Menopause, I feel, would be quite a big one too.
Ask them today. And sometimes this doesn't always happen on the initial consult, but there are some, and I'm not going to go through all of them, and we've made so much content on this because it's so important. There are some great, the Leaf Q is a great example. There are some really good questionnaires that you can send to people to do in their own time, but just getting an understanding of their feeling, because we kind of talk about this equation of overload plus inadequate recovery equals a bone stress injury. But I've just added in there as an example, overload plus inadequate recovery times the systemic factors, because those systemic factors can have such an influence on what's happening with the bone. And sometimes you see these people that have had 5 or 6 bone stress injuries, or this is their first one and it might be really different. They're just training for a marathon. That's very different to someone that's had 6 over 2 years and no one knows why it keeps happening. So screening for that. And what I will do, because I have the studies handy, I'll drop the link to those questionnaires.
Oh, I thought you were going to say to the studies.
To the questionnaires. Well, they're a part of the studies. Good.
Wait, you'll drop the link to the questionnaires?
In the show notes, yeah.
Oh, I thought you meant to your patients. Sorry. I thought you would give them.
No, some of them do like to talk about. I mean, it's awesome when they like to talk about it. It's cool. So we've spoke a lot about types of bone. Trabecular bone takes around 200 days to fully recover. Cortical bone take anywhere from kind of 120 and over. Good correlation between metatarsal and Achilles tendon forces, common fracture locations, and the one we need to be really looking out for, the higher risk ones, base of second and base of fifth, but they aren't going to be the most common. The most common one that's going to come into the clinic is a second or third in through the shaft. Like with the anterior tibials, like the tibia bone, these longer bones, they're going to be cortical, thicker, more tolerable to load, just to the area that it's in, the blood supply, of course, with the base of fifth, and then also the research reported on the rates of non-union.
Are we going to go into some imaging and diagnostics?
Yeah, so I think we'll do imaging and diagnostics after. I could kind of run through like I would in the consult. So someone comes in and they sit down And if it's the foot and the ankle, and I don't think you do this. I had someone that had a hamstring. So they had a foot injury and also a hamstring, and they come back in and just asked me to have a look at it. And I didn't actually ask them to take their shoes off, but obviously because I'm dealing with the foot and the ankle, that's the first thing that I'll say to someone, or one of the first things. Whereas you let them with their shoes on, hey, because I don't need to take their shoes off.
I get them. Most of the time, I'll get people to take their shoes off, but I often
Even for like a shoulder or back injury?
back often I will. Yep, socks on. I always keep socks on.
No way. I mean, go see those puppies. Go take those socks off.
I always say you can take your shoes off, but you can leave your socks on.
Oh, it's so awful when someone actually has no socks on. I go, take your shoes and socks off. I go,
When I say you can take your shoes, but you can leave your socks on, and they take their shoes off, and they're like, "I'm not wearing socks." I'm like, awkward.
So they take them off, and usually we ask them their story, what's been happening, introduce ourselves. We've been through all the communication stuff. Obviously, ask them to say and show me where it is sore and what the story is. And we've spoken time and time again on this podcast how important it is. We're still getting better at that. I guess it's a forever goal of really trying to understand someone's story and what's happening to them. But the person with all the information is in front of you and they will tell you what's happening. So, we know there's some research on, 80 something seconds, people.
Less than that.
11 seconds?
Yeah, it's something like
11 seconds where Allied Health cut the person off with their speaking. But if they point to their forefoot and they're a runner and it's saying it's really sore, straight away your suspicion has to be high. And
I always like to ask people, like, can you point to it with one finger as well?
Yeah.
Because sometimes they will be a bit vague, but if you ask them to be specific, they really can be. But if it's not specific, then they really struggle to even point with one finger because it is vague.
Yeah.
But if it's something more localized, then that's, to me, again, more concerning.
Yeah. And I'll do that because when they're sitting in the chair, I'll ask them to point. I'll get them to do that in the non-weight, like, can you make it sore? Can you really show me the spot? But they will, or they should clearly tell you a couple of things, depending on if it's more severe, like a fracture. And we'll just say bone stress injury, and that can encompass bone stress and stress fracture. But we really need to get a good grasp of their history because we're looking for clues as to why this might have happened. If someone's been really consistent and nothing's changed, well, that would be a little bit odd, and we might be suspicious of something else. Or we could be suspicious there's something else systemically happening. But usually, almost always, you're going to see a spike in training load. And training load is so varied. It could be intensity, it could be volume, it could be hills. The training load might not have changed at all, but they could have just been doing a race. They could have changed the shoes. They could have changed the surface. So we need to go really in depth with that training because it is going to inform also who this person is, and it is going to be more likely to be a runner. But you're looking at what they've done on their feet in the last 4 to 12 weeks. Sorry, the last 0 to 4 weeks, and then kind of behind that as well, because we know, I think the peak in that military study is
4 to 10 weeks post spike. Don't believe me.
3 to 12 weeks. 70% of bone stress injuries occur between weeks 3 to 12 of military training or similar sudden spikes. Good. So you're looking and you're really trying to work out what they've done. It's so much easier if they use Strava or they have a really good understanding of their exercise, but you're looking for that change. And I've seen almost, I feel not every version, but I feel like I've seen close to either they've started doing more plyometrics in the gym, they've started doing more intensity, they did a race. A really common one is, and I see this a lot with heel pain as well, people get sick for a week or two, or they have a week off, they go on holiday and they just jump back into their training as usual. So you're looking for some change, and usually it's going to be an increase or a period of a really low amount of load and then an increase.
I was just thinking as well of another patient who didn't necessarily have a change in their training load, but they got a puppy and they started doing a whole lot more walking and developed a bone stress injury. So if it seems as though you're not getting the answers that you're looking for, it might be worth also then probing into their other lifestyle changes that might include, weddings where you've just been doing heaps of dancing. I know that's been us, like on the weekends, we've probably done an extra 4 hours of plyometrics that we wouldn't normally be doing dancing, or like, getting a puppy and having to do a lot more training on walking with them.
Yeah. You're thinking like a bone, and bones are pretty dumb. They just know time on feet. But yes, you're looking for running, and that's pretty high bone load, but any other increases throughout the week, whether it be gym or walking or something like that. I'll usually ask them, like, how often do you run? Like, what's a normal run look like for you? Sorry, what's a normal running week look like for you? What's a normal exercise week look like for you? What's a normal work week look like for you? And then really, sometimes it can take me 10 to 15 minutes to work out that load. I had a case recently. This is an online case, and their training load had been really consistent. No big jumps, no more than a couple of kilometers each increase in a week since November. Had 2 weeks off completely. One went away, one went sick, jumped back into training and had a flare up of an old injury. And we were just going through the training load, and there was this dip and then increase. So that's what you're looking for.
Can we go in a little bit more detail through the palpation and the anatomy of how you would assess that as well?
Yeah. So asking where it's sore, asking them about their history just before that, just because it's important to get. When you're asking them around their symptom, there's a couple of things that we really look for. So if they're saying, I have pain in my forefoot, they're pointing along the metatarsal area. And, it's pretty easy to distinct the metatarsals. They're really long bone. If they're pointing on the midfoot, you're concerned. You want to make sure it's not the navicular. If they're pointing around the metatarsal heads, which is a common injury site as well. But if they're pointing over the metatarsal and they say, yeah, it's just gotten progressively worse, I've had to deselect from certain amount of training, because we're looking at, once you're over the edge, per se, we say you've reached the point of imbalance for the bone remodeling. Unless you really dramatically or aggressively unload it, and sometimes stopping running isn't enough, it's very likely to just progressively get worse. So we might see a tendon or some other injury and it's been much the same, but we're looking for symptoms that have gotten progressively worse, symptoms that have become more consistent. So pain at night, pain during the day, even when we're not on our feet, it's getting sore.
Yeah, I feel like that just a resting pain is
To be on, yeah. And they say it feels like it aches. It's sore. I had a big day on my feet. It may have been initially, I had a big day on my feet, and once I take my feet up, it feels okay. But with this, it's sore all the time. And the distinct one is it's sore all the time, morning and afternoon. Like we see with plantar heel pain, people get up in the morning, and even with their tendon, it might take 10, 15 minutes to warm up, and they might have a couple of hours with no discomfort, and then it progressively comes back. With these, it's like, yep, every step I feel it, because their foot's bending and the metatarsal
just has that
bending.
like ache, that constant ache and throb.
Generally doesn't warm up. Sometimes it may in the early stages, but yeah, you're right, that general throb. So consistent pain, and they're most likely to be a runner. You are suspicious. Get them up in the chair. Palpation wise, what do you do? What do you do to find that head? Oh, metatarsal shafts.
Just make your way down from the toes.
From the hip.
Yeah, from the hip. Just go down. I just find the toe and make my way down it. I mean, your toe is a pretty clear indicator of where that shaft of that correlating toe is going to be, right?
Yeah, I find, because the easiest anatomical landmark, you got a couple, you can find the navicular tuberosity on the inside, but I find if you grab the toes and you extend them and pull them back, what you'll be able to do is underneath the foot, you'll feel these prominences, and that's the metatarsal head. And if you pull them back, everyone's going to be able to feel them. There's no real person on earth that isn't going to have some prominence or bony.
Oh, you're palpating from the plantar part.
Hang on, we're getting there. So you pull back, and then you find the metatarsal heads. So you're on the head. So you put your thumb or you put your finger on the metatarsal head.
And then you go the opposite
so then you can put your finger on top. And you can do this the other way. If you pull them down, you don't always see, depending on if they're swelling, people will have a little bony bump there, and that's the joint line, and then you can work your way back. But if you find that metatarsal head, you go to the side, and you'll feel a space. That's the inner metatarsal space. So you got your thumb underneath, finger on top in the space, and the finger on top, you just move that to whatever side you need to go, and you're on the joint, and you'll feel it. And then you work your way down, and you should feel the whole way down. You should feel bone. It should feel thick. It should feel right near the surface. If you're feeling space or fluid, it's going to be the metatarsal space. Make sure you move the tendon off there, because you might have the extensor tendon. And in all cases, people have that distinct, they're like, that's really painful, really uncomfortable. And that's your metatarsal. And you think, well, what anatomical structures are going to be there? Could be differentials, intermetatarsal space. It's unlikely based off even the symptoms, but they won't have that much discomfort depending on how bad it is. But on the shaft, it's just the shaft. That's the only thing that's there.
You just have it easy down around the foot because everything's so superficial.
Yeah, we do have it pretty easy. Everything's so bony, like the surface anatomy.
Yeah,
Maybe
so
that's why I put so much emphasis on it because you can really feel like, yep, here's the styloid, here's the navicular tuberosity, here's the navicular, here's the anterior ankle. Like you can really get a good
but
understanding.
again though, how often would you say there is a generalized sensitivity around that region?
Yeah, there is. Even if they have, I guess, if you look at it, if we take it really broadly, and I can't remember, there's an equation for this. Maybe it's like a quadrant equation. It's like the sensitivity and specificity, maybe. But if you're looking at, I want to rule out that it's not the metatarsal. What's the likelihood that they have intermetatarsal space pain and the metatarsal shaft pain versus it's just the intermetatarsal versus it's just the neck?
Mm,
You wouldn't expect someone to have distinct shaft hesitancy and discomfort
yeah,
when you're palpating the space because that's nothing to do with the bone, and you're not going to see a lot of fluid come dorsally
and also
between the bone and the surface area.
the just the general pattern of pain would be so different. Like
Oh, for
intermetatarsal
sure.
would
There's
be
no way
so
to
like
check it. Yeah, yeah,
inflammatory style pain, whereas where it like worse in the morning, warms up a bit with activity,
for sure.
worse after activity.
Yeah, yeah,
Yeah.
for sure. And someone of a runner, intermetatarsal space lesions are common, but again, you're not expecting them to have distinct hesitancy. And if you have someone come into the clinic, they're painful. They will either try and pull away or they're sore. A lot of the time, I don't think I've definitely had it when they're asymptomatic, but I haven't ever been able to apply the normal amount of force that I do to a metatarsal stress fracture because it's too painful. As soon as I start, and I've had some big blokes come in, and as soon as you palpate a little
Mm.
bit, they're like, whoa, like they're pulling their foot away.
Are you ever seeing like are they ever reporting to you? I've never seen it, but just because I know you see a lot more of it, but are you ever seeing people report pain from like the plantar surface that's a metatarsal bone stress injury, and would it ever be pain palpating from the plantar aspect, or would that be more a differential, something like a plantar plate perhaps, or something like
Yeah,
sesamoid or different?
yeah, it's not usually not too because that's a bit more distal, but maybe like a flexor sheath or maybe it's arch discomfort. But in the severe cases when there's quite a bit of edema, yeah, they've got some pain plantally, but it's nowhere near as much as what it is dorsally.
Yeah, so
So
or like never plantally without dorsal pain.
yeah, and when you think of like the anatomy of a bone stress injury, it is to the dorsal surface of the met. So even if you were to apply a lot of force to the plantar surface of the metatarsal, because the metatarsals are relatively thick, the bone stress injury or the potential fracture line or cortical breaching or edema isn't going to be through there. So they don't have as much discomfort. It's a bit like a smaller version of someone has a stress fracture to their tibia. Rarely do they have pain down the front of the shin when you're pushing
Mm.
into it. So you're pushing into a different area. But I find that palpation is more than enough. The one where it does get tricky is the base of the fifth because you do have the peroneus brevis that comes down and inserts onto there. And, it can be an insertional tendinopathy, but you've also got the base of the fifth and it's a high risk area. So fifth met shafts, pretty easy to palpate. And you'll see on most people, they have a little bony bump. That's the styloid process. So, distinctly there is some discomfort around there. With those symptoms that we spoke about, pairing your palpatory skills with your subjective skills versus the person in front of you, even if it is behaving a little bit like a tendon, you need to make that clinical decision whether you believe they need a scan, because that's obviously not one that we want to miss. I mean, we never want to miss any injury, but the bone stress ones are really important.
Hmm. Yeah,
Yeah.
I think that's clear. That's
Now,
good.
people do the fulcrum test, which I am not a big fan of because I don't think it really adds too much
No,
value
and I
where you would grab the base of the mat and you bend them down. Like, well, if they've got tenderness on the shaft and I've got these symptoms, I don't really need to do any more damage to it, do I? I don't think it adds that much value. I've seen it be positive and not positive, but I'm not aware of any data on that.
I feel the same about the fulcrum test in the femur, to be honest.
Yeah. Do you ever do that? We did it on you when we thought you had.
I mean, I like in maybe in some cases you do it, but I don't think it, as you said, like I don't think it really adds any more. Like if I'm suspicious of a bone stress injury and they're giving enough signs,
Mm.
then I don't think it's going to change my decision making around whether it needs to be investigated or not.
Yeah, I agree. I agree. So I'll take them out off the chair to do the weight bearing test. There is, let's get your opinion on this. If you're suspicious in the foot and the ankle, and I guess it's the same for any BSI, and I know Greg Lehman he posted something about his organization was, um, he's like, it's like the regulatory body. They send him some questions and he has to do an exam, and it's kind of to assess your clinical competency. And he had a femoral bone stress, and he was like, I wouldn't get them to hop if I've got enough from my
Mm,
clinical assessment, because if I'm suspicious, well, for these higher risk ones, if it's bad enough, and we know symptoms don't always correlate with the severity of a bone stress, I could make it a whole lot worse. So I can definitely see the argument for, and sometimes this is the case where I'm just like, we just need to get a scan. I don't need you to go and hop, but that is another clinical test that we do use. What do you
mm.
think?
Yeah, I think it depends on the case. I think in the case where someone's like, are we talking about metatarsals or hip at the moment?
We talk about all.
Yeah, like if someone's hobbling in and they have like distinct tenderness over the metatarsal and maybe even some swelling present and they are pain with walking, pain with double leg calf raising, like I know it's going to be sore with jumping and hopping.
Mm,
So I wouldn't do it in that
yeah.
case. And then same thing for the hip. Like if they're walking in and it's painful and they've had night pain and resting aching pain and they're a runner
Mm.
and male or female, then again, like I'm pretty sure it's going to be painful with hopping and jumping.
Yeah, and if you've already made the decision and spoken to them, and I've usually said that to them, like, we want to be clear that this is not a bone stress injury, and this is all the tests that we're doing. If you've, in most cases, in the severe cases, you've made your decision, like you have this, and this. We need to get a scan. It's not that much value, and sometimes the consult ends 35 minutes in because, and when we have the hour, like there's nothing more that we need to do until you get this scan, but in the less severe cases, it's definitely a good clinical test because it does apply the most amount of plantar flexor force, which applies the most amount of bending to the metatarsal. So, as you said, it's really important when you get them to do these tests, you're asking them where it's sore. Because anything below the knee, I mean, anything in the lower limb, hopping's a really high load. So they're like, yeah, that's really sore. And they point to their Achilles. Well, that's going to be different. And people can have multiple pathologies happening at the same time. So you do need to be sure that it is that area.
Yeah, agreed.
Yeah. Any other tests that you'll do? Weight bearing?
Just sometimes I'll get someone, well, I'll look at someone walking and then I'll see how they go walking on their toes and see how they go walking on their heels. And then calf raise, double leg, single leg.
Yeah, that's a
I'll
good
have a look
point.
at just like their ankle range of motion, maybe have a look at like a knee to wall.
Yeah.
But that's probably it.
Yeah, that is a good point of building them to that. And we do that with
Yeah.
tendons as well, like walking, tiptoes, maybe heels, double leg raise, single leg raise, maybe some pulses, double leg jumps, single leg jumps, maybe a triple hop. And, they're getting discomfort over that area with a double leg calf raise. What clinical value does it give you to get them to hop? Because
Mm.
it's likely to potentially make it worse. And you've already made your decision. It's just about communicating it to them, coming together to make the decision together, and then
But
going
then
from
what
there.
about someone who you do a like all of that double leg calf raise, single leg calf raise, pain free, single leg calf raise off a step, pain free, jumping, pain free,
Pain free.
hopping, pain free? Are you ruling out a bone stress injury in that case?
Well, I don't think I haven't seen one that has been pain free to hop, but based off what if they've got pain on the shaft and through their subjective history, they're telling me that it doesn't warm up and it's always there, and they are noticing it most of the time throughout the day. I think, and again, it's hard to say in exact cases. I would be a lot more likely to still send them for a scan, because when I think of it in my mind, I'm thinking, what am I suspicious of? I'm
What?
suspicious of a bone stress injury. What do I need to be sure to rule that out? I have my clinical test, which I do rely on, but I have an option here. I communicate that to the person to say, these are the clinical signs and symptoms. It's not enough to say distinctly I'm 100% confident, but we do need to get a scan because it does change our treatment. And I've got that there. I remember, as one of the sports docs at work would say, like, if you're suspicious of what this is and you need to be able to order this test to be able to confirm that, well, you need to do that. And obviously you communicate that with the person and it's you guys make that decision together. But I think I would send a scan. What would you do?
I'm just thinking this is a separate, not a metatarsal, but a case that I had recently of someone who we were managing their shin splints for ages, and so had been progressively increasing their running, their jumping, their hopping, like they were doing heaps of jumps and hops in their rehab, and then
Pain-free?
had their shins have been going really well. Back to their sport, soccer, back playing soccer, training. We're about to go back to playing like the game, and they just had this like onset of pain that came around them. They're sort of like midfoot, but sort of tib post area. It was quite vague during training, and it caught them quite intensely and suddenly, and they were hobbling for the rest of the session and couldn't quite get through and ached afterwards. Didn't have night pain, but sore with walking for a few days afterwards. And I was like, shit, do you have a navicular bone stress injury? Yeah. That was my concern. But then in the consult, couldn't really reproduce their symptoms, and no pain with jumping.
Really?
Yeah.
Yeah.
More pain, no pain with jumping, no pain with hopping, triple hop, triple crossover hop, side to side hop test, not painful. Painful with like resisted inversion. And so I was like, okay, I think there's enough here to say that it maybe your tib post tendon's a bit cranky, but I don't think that we're dealing with a bone stress injury.
Yeah.
Yeah,
it sounds right. I mean, you wouldn't expect something got pain with inversion. You'd almost think that's a like a tenosynovitis.
Yeah. Oh, yeah. That was kind of what I was more
Because
thinking.
it's such low tendon load, and also it's not enough load. You wouldn't expect that amount of load to apply enough force to the navicular to make it sore. And the navicular is same as the met. Like if you find that point of the navicular, because it is the C shape, I think in Nolaris, between boat shaped in in Latin. My topic. We did a podcast on navicular stress fractures a couple on ago. But if you find that tuberosity, then you can just go over an arc and you can kind of palpate.
Yeah.
I agree with that. But pain with
it was like, the no pain on hopping basically was the thing that I was like, well, I feel better about. I don't think we're dealing with a bone stress injury. Then then we continue to talk about no ache that came on afterwards either. So in my head, that's sort of a way for me to almost rule it out. But I don't know. Should that be? Should I be more concerned about it?
Well, when we say rule out, we almost do say it like we're saying it can never be. And
True.
It's never the case in healthcare. You make that clinical decision.
I'm less suspicious right now, and we're going to try to, we'll treat this as a tib post tendinopathy or tenosynovitis. And if it tolerates that and progresses well, great. And if it doesn't, then we investigate.
Yeah, and that probably speaks to the broader layer of us dealing with human beings, where we know a lot of the time those special tests that we have aren't so special. So we just need to use our clinical judgment. But I couldn't agree more with that. And as long as you've got the parameters in place, I think for someone to understand, when do I actually really need to pull back? Like, hey, it doesn't look like an injury to this bone. It looks like the tendon next door. But if this happens, I really do want you to let me know, or I just want you to stop completely and we'll catch up again, which is like pain any worse with activity, pain over the top of the foot and whatever it may be. I was thinking when you said that as well, because I thought you were going to say with the shin related pain, and you do see this sometimes in the foot, but more with the shin, where someone has had some discomfort for a long time and the symptoms haven't gotten worse, and they've been able to maintain, let's say they're a runner, they're able to maintain like 20 or 30 Ks a week. And you're like, is this a bone stress injury, or is it some other soft tissue injury, the periosteum or the tendon or a tenosynovitis, whatever it may be? And I think in those cases that it makes me less likely to think that it is a bone stress injury, because if it is, it should only progressively get worse, because you can't have I'm assuming you can't have the remodeling suddenly increase really quickly like the damage or how quickly the bone gets damaged. That's the thing. And once that happens,
We
it's
don't know that
heals.
though, because there's never been any study done in like a decent amount of people
Mm.
that says that you can't rehab a bone stress injury through symptoms.
There's the one.
Well, yeah, that's
That's
what I
the
mean.
one.
There's
Yeah.
one,
And
and it's with
no
one
difference.
person.
Yeah, no
So
difference.
we don't know that that can't be a bone stress injury that's just remaining stable through a stable training load.
But I don't think it can remain stable based off the physiology, because once you have, because the timing is different. So as you said, the guy that has to go away to get the dirt to fill the hole in, the person digging the dirt, you're assuming if that stays constant, the person digging out the hole stays consistent, then, and let's say that's the 20 Ks per week, the person has to go and get the dirt. So eventually the hole is going to get deeper and deeper.
But the body is also going to adapt.
Yeah, but I don't think that on a physiological level, I don't know if the bone is going to adapt like that, because the adaptation, we know about the adaptation is that imbalance, and we're not going to talk about the cellular mechanisms. But so you're saying that, and I'm saying certainly could be possible, but it seems much more likely that you can't have them, so you can't do the damage and then they be equal. I don't think you can like.
I don't know. I see.
I don't think you can.
I don't think we know.
But we know about there's a lag.
Yeah, but if then someone backs off their training load, like say they were previously running like 50 Ks a week and they backed it off to 20,
Yeah, that's a good question.
can you keep training?
Well, I think the bone
Because that's a lot less load than they were dealing with before. So is that enough of a deload for it to then catch up for Mr. Man who has to go get the dirt from a bit further away to fill the hole?
bone is damaged. The bone is damaged.
Yeah, and the load has reduced. It just hasn't stopped.
Could you say that it wouldn't be able to catch up, because if it could catch up, we wouldn't need to put people in a boot. We could just get them to walk around and it would heal.
But we sometimes do that if people aren't.
Rarely do we do that. Like,
Well,
rarely
if
do people not
it
have
depends on where maybe for you and the foot, but up around there, it's not like if someone's pain-free walking with a neck of femur or a femoral shaft or a sacral bone stress injury, you don't always put them in a boot, or a tibia even. If they're pain-free walking, they don't need to be in a boot.
How often do you see that pain-free walking, but pain with running and a bone stress? I don't see that very often.
I see that.
Often?
Mm.
More or less like
In people that come in fairly early, yeah.
Yeah. So they have, okay. So you wouldn't see stress fractures, would you? I don't think I've ever seen a stress fracture that's not painful with.
No, I'm not talking. No, not a fracture.
Okay. So you'll see a low risk bone stress where they have no pain during the day, which is with walking.
Yeah.
Okay. Yeah, I agree. We don't know. I just think that timing makes some difference. But
Or it's someone
oh,
who.
here we go. No.
I mean, it's someone who's just not going to go onto crutches. Like, it's just not feasible. And they're like,
Well, no, I'm
they're,
not saying either. I'm just saying, could it be could someone, sorry, back like 10 minutes ago, could it be a bone stress injury if they've been able to maintain the last 4 months of training with pain at 20 to 30 Ks per week, and they haven't had to had a week off? They've just been able to maintain. I don't know, and this is
yeah, I don't know either.
Could it be like, you just imagine the two yin and yang?
Yeah, they're just fighting each other.
Yeah, but they're not.
The man that's got the dirt further away, he's just
He's
like,
feeling at the same time.
Let me fill it up.
Yeah, so you got to be, and I mean, of course, these things in healthcare can happen, but what I'm saying is I don't think that's the case, because of what we understand about the time frames and that remodeling process. No, I'm back here. No, no, it can't happen, because the bone that's being laid down isn't the bone that's been there for 6 months. We know that when you take away, so when you have the breakdown in that site, let's just say it's size of a 5% piece, you take that away, that area is more compromised and it's less tolerable to load. And the new bone that gets laid down, that bone still has to change. And that's when we're talking about how long trabecular and cortical bone takes to kind of mineralize, per se, for lack of a better word. So
yeah, but even when you're offloading someone from a bone stress injury, you're not offloading them for 200 days for that bone to mineralize.
No, but
because remember, load is still good for bone.
Yeah, but to the point of where the bone's at, and where I'm saying running.
But if that's still less than what their baseline, no, I don't want to go into it because I don't want to go into just like hypotheticals. I just don't think we know,
Yeah.
is all I'm saying.
All right. But to our listeners, we would, of course, if we were suspicious, we would of course say don't keep
Don't
running.
run. Yeah, don't run.
We just like to really question it a little bit. Good.
Are we done or
Yeah,
are we
I
going
think-
into imaging, X-ray,
yeah.
MRI?
We did want to speak about, 'cause we're not going to talk about too much around diagnostics, but for the gold standard for these is going to be an MRI. Of course, you write the location, what you're suspicious of. Do you need an X-ray? Don't you need an X-ray? In the earlier stages, it's going to be less sensitive. In the later stages, it's going to be more sensitive. I think from looking at exposure to imaging, I think an MRI is enough. And what is the X-ray going to change? Potentially, maybe we'll show you a fracture line, but having an MRI first, using your symptoms and also your objective tests, I think is going to be enough to manage it successfully. If you are suspicious of a high risk one, and there's two kind of caveats to it. If you're suspicious of a high risk, it needs to be boot and non-weight bearing. So it needs to be boot and crutches until proven otherwise, and very likely a sports doc or an orthopedic opinion. If you're suspicious of a low risk one, of course they're going to go into a boot. But even if you're suspicious and someone's just got a whole lot of pain, well, they probably need to go into a boot for a week or two anyway, just to help settle the symptoms. I mean, I've seen cases where it's really painful, and this is usually in people that spend a lot of time on their feet. It's incredibly painful. And we do this with other conditions as well, like heel pain, Achilles. It's so painful that we don't have any other way to offload it, and they can't offload it during the day. So we're going to put them into a boot anyway. So they're the kind of three groups of people that I would see.
Yeah,
Yeah.
I think that's a good summary.
You would change it because, as I said, we can always take some.
I guess like sometimes you can suggest particular types of footwear if they're kind of in that in between category of like they're a bit limpy with walking. Going into a boot might not be feasible, but they've got some like stiff rockered bottom shoes at home that they might be able to wear to help offload it.
Yeah.
Could be an option as well.
Yeah. I had a case recently, and you just brought it to front of mind where it is the case where I will push back a bit on that because, the first time we're like, yeah, I can't wear a boot for work. And then we have to go on to kind of explain, well, this bone, it's being overloaded and overstressed at the moment. We need to offload it. And you do 15,000 steps a day on your feet, walking around a hospital or walking around like maybe you're a construction manager and you go on and off the job site or whatever it may be. I know sometimes it's not feasible, but we really need to kind of come to an understanding. And I've done that before, do I need to write a letter to work? Do I need to say this is medically indicated, you have to be in some kind of offloading tool? Because if not, there are really associated risk with it fracturing, you potentially needing surgery, having more pain, more time off. But yeah, I do agree. For the metatarsals, because the plantar flexor force is the thing that we're trying to unload. A good stiff rocket shoe, the Glycerin Max, the Hogepondi 9, the Ghost Max 2, the Saucony Ride with a heel lift is really going to help reduce that plantar flexor force. And as you said, if they're getting around symptom-free with those things in place, and it's a low-risk area, and you've assessed their overall systemic health, then you can definitely use that as the unloading and take your typical time off and then rebuild back to normal.
Mm-hmm. Yeah.
Sweet
cool.
as.
This was going to be a quick podcast, but it's gone for an hour. I knew it would go for longer than we said.
Yeah.
This happens.
It does.
But it was fun. Good to get back on the mic.
For sure.